Very good morning. I present a 33-year-old male, living spousal donor allograft recipient, who has come to us in April with graft dysfunction. I go back to 2019 when he had his native kidney disease and was getting treated elsewhere. He had presented with advanced renal failure in small kidneys and was presumed to have a chronic glomerulonephritis. After 2 years of dialysis vintage, on February 2021, at a private hospital in New Delhi, he had undergone transplantation, ABO compatible with ATG induction. We do not have much access to his pre-transplant immunological workup right now, except the fact that HLA mismatch was 5/6 and his CDC was negative. His donor was wife, and he had excellent graft function. His KTU stay was uneventful, and he was discharged with a creatinine of 1.2. 1 month later, that is in March 2021, he had acute graft dysfunction. Renal biopsy was reported as acute cellular rejection elsewhere, and he was given IV methylprednisolone 250 milligram, 3 doses. And his creatinine, as you can see here on your right, at presentation it was 2.9, and it had settled to 1.7. And then about 3 months later, 3 months post-transplantation, he had a severe symptomatic COVID infection. And the clinicians there were forced to tamper with his immunosuppression, and his MMF was reduced. Oral steroid had been increased, and tacrolimus was continued, and he had a 15-day hospitalization. And starting from that point in time, unfortunate for the patient that he had infections. In June 2021, he had tuberculous lymphadenopathy, and he had taken ATT for 1 year. He also had drug-related complications. In July 2021, he had chronic diarrhea, no identifiable etiology as per reports from outside. His mycophenolate was stopped. He was continued on dual immunosuppression. Now, I will take you to his creatinine trends. 3 months post-transplant, his creatinine was 1.9, and graft dysfunction never seemed to have settled. His creatinine was 2.1, and then subsequently, when he had the diarrhea, he had 6. And then when MMF was stopped, it came down to a baseline of somewhere between 2.8 to 3, and it settled there. Coming to his tacrolimus was more or less graft age appropriate. And after another episode of otomycosis in Jan 2023, he changes his primary care nephrologist from Delhi and he had come for a consultation to us in our OPD. And on examination, he has come for graft dysfunction. His creatinine at that point was 4.1 when he came to us. He had clinical examination showed pallor, pedal edema, and he had hypertension, BP of 150/100, requiring 2 antihypertensive agents. The rest of the systemic examination and allograft on physical examination was no abnormalities were detected. He had an output of 1.5 liters per day. To take you to the labs, hemoglobin, he had anemia, hemoglobin of 10. He had advanced graft dysfunction with a creatinine of 4.1. His tacrolimus was slightly high. We would have liked it to be somewhere between 5 to 6. It was 7. Urine analysis showed 2 plus protein. He had a 24-hour urine protein of 1.2 grams. Serum BKV, which was done, and we got the report prior to admitting him for biopsy, it was negative, and there was no significant finding on the graft. He could not afford a single antigen beat a donor-specific antibody assay. We got him admitted within the 1 week of his OP consultation for an allograft biopsy to exactly know what was going on with this graft. Our provisional diagnosis was, yes, this patient is having chronic renal allograft injury. I am tempted to think that it is immunological because he had a high-risk transplant. Someone were prompted to give ATG, and possibly he had some DSAs pre-transplant itself. And he has also had an immunological event. He has had acute cellular rejection in the past, and he is on dual immunosuppression. So these are the points that are favoring possibly an immunological cause of acute on CRI, possible combined versus chronic antibody-mediated rejection. I would also like to rule out the contributions of these infections into the allograft, other non-immunological injuries. Over to the transplant pathologist.
Good morning to all. For this case, we received a single linear tissue piece, which was measuring around 1.2 centimeter, and whole of the tissue was embedded. Now, as we can see in this low part as well, there's a lot of inflammation in the biopsy. In this cortical region, which is seen, there's a lot of inflammation, and there's also because of that ongoing inflammation, there's also loss of tubules. So, on basis of this, we can label it as I3, that there's a lot of inflammation. And after which, when we deal with the separate compartments, first coming to the glomeruli. So occasional glomeruli was showing some interest. There was some leukocytic infiltration. So in some of the glomeruli, so it was reported as G1, as we can see, which are highlighted by the arrows. Surrounding peritubular capillaries, as we can see in this one, there is three leukocytes in this one. And in other hypas, we can see that there are multiple peritubular capillaries, which are showing infiltration by 1 to 4 leukocytes. So it was reported as PTC1. So till now, we have G1 and PTC1. Now coming to the tubular compartment, the tubular compartment, we were able to appreciate some leukocytic infiltration as well. So there was around 1 to 4 leukocytes in some of the tubules. So this was also reported as T1. As we can see, this is another tubule which is showing leukocytic infiltration. However, there were no viral cytopathic changes that were noted. Other than that, there was mild tubular atrophy, and also there was marked acute tubular injury. As we can see, there is dilatation and simplification of the lining epithelium. Coming to the interstitial compartment, again, we saw there was a lot of fibrosis. So it was reported as I3. And after this, we went for immunofluorescence. In this, 5 glomeruli were seen. And for C4D, around 10% of the peritubular capillaries were showing positivity. Other than that, there were no immune deposits for IgG, IgM, IgA, and C3. So taking in account on all the findings that we saw, that there was G1 and PTC1, along with that there was tubulitis and also interstitial inflammation. This was reported as a mixed rejection, as an acute antibody-mediated rejection, along with T-cell mediated rejection. And there were no viral cytopathic changes which were associated with this. C4D was positive.